Good evening. I'm Dr. Susan Crow, the District 9 Section 2 Chair, representing the San Francisco Bay Area. Welcome to our town hall focusing on anti-racism efforts. We welcome our ACOG members and we extend a warm welcome to our guests. I'd like to thank ACOG for making a powerful statement about our commitment to changing the culture of medicine and eliminating racial disparities in women's health outcomes.
Hello, my name is Dr. Richie Sella, and I'm the Vice Chair of Section 2 of District 9. I wanted to start off our conversation with this quote by Ijeoma Oluwo. "The beauty of anti-racism is that you don't have to pretend to be free of racism to be an anti-racist. Anti-racism is the commitment to fight racism wherever you find it, including in yourself, and it's the only way forward." And now I'd like to introduce Dr. Maura Jones from UCSF.
I'm Dr. Maura Jones. I'm a second-year OB-GYN resident at UCSF. I was asked to just say a few words tonight before I introduce Dr. McLemore. So I'm just going to start off by sharing a patient story that I think helps to kind of highlight the numerous ways in which racism and anti-Blackness impacts our patients. A Black patient presents to the clinic for a new OB intake. Her partner, while getting settled in the exam room, a clinic staff member makes an assumption that the patient is a single parent and applauds her bravery for doing it on her own. The patient brushes off the comment and says that her partner is downstairs. The patient and her partner are seated when you come into the room a few minutes later. The patient appears a little annoyed, but warms to you and is visibly excited to hear the fetal heartbeat on the dating sono. You counsel her and set her up for her follow-up visits and wave her goodbye. On her way home from the clinic, her and her partner are pulled over by the police. Her partner is subsequently harassed by the police, but eventually they let him go. But the ordeal is very stressful for the patient, and she questions if her own children will be harassed in similar ways. She thinks, what if I have a boy? They proceed to finish their drive home, where in their neighborhood there is toxic waste from a nearby plant polluting the water. The patient is committed to eating healthy this pregnancy, as you've counseled her on the importance of nutrition. She does a Google search and notices that the nearest grocery store is miles away, but there's a McDonald's across the street, and money is tight. They begin to research schools in the area as they vow to give their child a better education, and notice that most in their area have poor ratings and are underfunded. They start looking at properties in other neighborhoods with better school ratings, but their loan applications are persistently denied. The patient feels hopeless. She returns to clinic in 6 weeks for a follow-up visit. This time, she's visibly scared and upset as she has done research and is aware of the poor outcomes Black women have in childbirth. Someone close to her has died in childbirth. She trusts you and asks for your reassurance. What will you tell this patient? Now imagine if she is seeing a physician who is not from the Black or Brown community or who is not doing the work of anti-racism. How might that affect her care? What if, like many of our patients, she was not comfortable sharing that fear with you? Racism is a pandemic. It is the pandemic. It has been raging in this country for centuries, killing Black and Brown people both inside and outside of the hospital. And we have a duty as healthcare professionals to speak out. We must speak out against systemic racism and systemic violence against Black and Brown bodies. Choosing to remain silent perpetuates the isolation of Black and Brown colleagues, learners, and patients. Choosing to remain silent is violent as it maintains the status quo of racism. A status quo in which Black men and women are being unjustly murdered by police. Black women are 3 times more likely to have complications from childbirth, including death. Black people have been disproportionately affected by COVID-19 and are more likely to die from its complications, and Black infants are twice as likely to die as white infants. This movement is not just about ending police brutality. This movement is about ending the systemic racism that allows police brutality and all of the disparities that I listed before to exist. Black people have been speaking up for generations, and we will continue to do so, but we need you, non-Black folks, to speak up, and more than anything, we need you to do something. What are you doing to change the lives of those around you and those of your patients? What are you doing with your money to show that you support this cause? What will you do the next time a colleague or a patient makes a racist comment against a Black resident, doctor, or nurse? What discussions are you having at your own kitchen table about racism? Silence is simply not the answer. I am excited that we are hosting this town hall and hopeful that it will be a tool to help you answer some of the questions I have posed and will inspire us all to take action. Next, I would like to introduce our esteemed guest speaker, Dr. Monica McLemore, who I have admired from afar for 2 years now, via Zoom. At the University of California, San Francisco, Dr. Monica McLemore is a tenured associate professor in the Family Health Care Nursing Department, an affiliated scientist with Advancing New Standards in Reproductive Health, and a member of the Bixby Center for Global Reproductive Health. She retired from clinical practice as a public health nurse and staff nurse after a 28-year clinical nursing career. Her program of research is focused on understanding reproductive health and justice. To date, she has 61 peer-reviewed articles, op-eds, and commentaries, and her research has been cited in the Huffington Post, Lavender Health, 3 amicus briefs for the Supreme Court of the United States, and 2 National Academies of Science, Engineering, and Medicine reports. And the data visualization project entitled How to Fix Maternal Mortality, the First Step is to Stop Living Women, that was published in the 2019 Future of Medicine edition of Scientific American. Her work has appeared in publications such as Dame Magazine, Politico, ProPublica, and NPR, and she made a voice appearance in Terrence Nance's HBO series, Random Acts of Blindness. She is the recipient of numerous awards and currently serves as the chair-elect for Sexual and Reproductive Health section of the American Public Health Association. She was inducted as a fellow of the American Academy of Nursing in 2019. So without further ado, I'm going to turn it over to Dr. Monica McLemore.
Maura, thank you so much. I'm glad we're finally meeting. You know, I mean, we've met on Zoom like a million times, but thank you so much for that kind introduction. And Richie and Susan, I'm very grateful for the opportunity to talk with our colleagues and to create a simulation space for us to have some difficult conversations that are long overdue. And I have to say, today feels like it feels like a renaissance in a lot of different ways. I feel like I should put my Stanford gear back on because I had an opportunity to talk with the Highland Hospital physicians this morning, the OBGYNs and the primary care docs, and to talk to Kevin Smith is reminding me of our time at Stanford many, many years ago. I look really young, but people forget the fact that I actually turned 50 on New Year's Eve. And the background behind me is Disneyland Paris, where I spent my 50th birthday, 12/31 of last year, of 2019. I was born 12/31/69. And I tell you that because my birthday really should have been February 14th of 1970. So I was born in preemie in 1969. And I have to tell you, I grew up in New Jersey. And at that time, the Public Health Service, the National Center for Health Statistics, calculated that the total infant mortality rate in New Jersey was 20 infants per 1,000 live births, that 16 out of 1,000 was the rate for white women. And because they did not collect statistics on ethnic and racial minorities at that time, 1969, year after the Civil Rights Act passed, the infant mortality rate was 35.3% for all other races and ethnicities. So I'm both grateful and lucky to be alive. And I say that 50 years later as somebody who, like many of you, have taken the oath to serve the public for people with the capacity for pregnancy, that this is frustrating, it's shameful, but I'm here to tell you, we can actually do something about this. I'm not sure how many times you've had nurses come talk to you, but I'm grateful to be one. And I have to say that, you know, when the World Health Organization decided that 2020 was going to be the year of the nurse and the midwife, I somehow didn't really think this is where we were going to be, right? So part of what I'd like to do today with the time that I have with you, I want to give you 5 important tools. 2 of them are actual tools. 3 of them are going to help us look at power. And think about them as something I like to call split, because that's where we are right now, right? People are feeling frustrated, like emotions are high. I want everybody to take a breath because like it's the end of the day. Some of you have worked clinically. I may be rejoining the clinical workforce and coming out of retirement, by the way, because I set myself up to do some contact tracing because I'm a public health nurse by training, even though I've only worked in obstetrics and gynecology my entire career. So take a breath, everyone, because we're going to talk about the split, okay? I keep using the word split purposively because those are the first letters of the first words of it. It's an acronym. And I'm trying to give people tools because we need everyone to be doing work. We need white people, we need Latinx people, we need Asian American people. We need y'all to do some work. And because you are our trusted colleagues, because we took an oath to care for the public, I'm going to try and say this in as many ways as possible to bring as many of you along, because I'm going to tell you two really important things. Number one, this all really could still be different. And if the last 10 weeks have not taught you this, I'll give you some examples. And number two, Black people are tired. We're tired, we're frustrated, we're sad, we're grieving. We need your help, and I'm gonna tell you how to help us. And not all Black people are gonna do this. We're not a monolith. We have to get very comfortable with incremental changes. I know a lot of people who are out on the streets want stuff to change tomorrow. I want stuff to change tomorrow. Okay, so just so that we're being very transparent, I'm gonna give you some tools to incrementally be able to use, because I know everybody doesn't want everything to change tomorrow, because if we all did, it would. And you have to fundamentally believe that. We're not in a position yet for collective action because y'all and us and we have work to do. So let's talk about the split. This meeting is part of what I like to call a simulation. We need places to practice safely, right? It's not Facebook, I'll tell you that much, right? People get mad, emotions get high, you block somebody, you move on. That's obviously not the tool that we need to be using right now, right? At the same time, we have so much misinformation that many of us need to be there to counter the misinformation, right? So remember, your racial equity work is not just your social media presence. It can't be. These spaces have to become simulation. Everyone has gotten it in their heads that we need to practice, hemorrhage kits and crash C-section. We practice simulation. Simulation is a tool we should be using for racial justice. And how should we use that? Here's the simplest way to do it. Adopt oops and ouch. If I say something that's really painful during this discussion, or somebody else does, type oops in the chat box, right? If I screw up, I'm gonna type oops. I'm gonna stop myself and go oops. If I say something that really hurts, ouch, ouch. Like, acknowledge the pain, right? Don't sit with it, don't fester, don't fluster. Let's get back to authenticity in the clinical environment, right? Oops and ouch are very simple. You can type it simply into the chat box, right? Oops, Monica, you gave a wrong statistics. Oops, Monica, did you really mean to say that? Ouch, Monica, damn, that really hurt, right? It sounds kindergarten, but interestingly, when an entire group of people decide that that's the public accountability they want to be able to have to each other in spoken communication, it actually works very, very well. Simulation is the S of split. P, public health. One of the things that I really, really don't like about nursing and medicine, and I'm only going to talk about those two disciplines. I mean, social work probably does this, but when we think about healthcare hierarchy, we are it. And one of the things I don't like is we think we have to recreate the wheel in anti-racist work. And I want to let you in on a little secret. Public health has been working on this for 30 years, okay? I put this book in the resource section. You probably can't see it because my background is on, so I'm gonna change my virtual background back to none so you can see it. This is Dr. Chandra Ford's book. She edited it. It's from the public health, and it's entitled Racism, Science and Tools for the Public Health Professional. Guess what, those of us in health services provision? We actually probably should sit down and listen to our public health colleagues. Why? Because they've been working on this for 30 years. How many people on this webinar knew that Dr. Maura Jones, under her leadership as the past president of the American Public Health Association, started an anti-racism campaign during her presidency in 2015. There are 5 archived webinars, national webinars that she conducted in 2015. She decided to revitalize that whole webinar series, and the first one was yesterday. She was on it with Dr. Amani Allen, who some of you may know as Amani Nuru-Jeter, who is the executive dean at UC Berkeley School of Public Health. Brilliant researcher, lucky enough to call her a friend. I will be on one of those webinars with Dr. Elizabeth Howell, who I know many of you know, who's left New York to go to chair the OBGYN department at Penn, and Joya Correa-Perry, my other good friend from the National Birth Equity Collaborative. We're going to talk through, racism in maternal health and what public health professionals can do. That's going to be number 3 of the webinar series. There are going to be another 5. Public health has tools. We don't have to lead here. We can actually model the behavior that we want to see because we can actually let public health lead in the same way we've allowed them to do so in COVID-19, right? If there's nothing you hear from me from the split, it's that public health has been working on this for a long time. We do not need to come in and Columbus the important work that they've done. We need to read their scholarship. We need to read their science, not the cliff notes, but we need to bring those experts in to assist us and to help us understand how to do this differently. For those of you who are more hardcore, Nature Science Cell or, New England Journal of Medicine and JAMA types, read Dr. Rachel Hardiman's piece in the New England Journal of Medicine that dropped this afternoon. She co-authored it with pediatrician Dr. Rhea Boyd. It is incredible. And her husband, Eduardo Medina, who's a physician, they're at University of Minnesota. And it's called Shallow Breaths. And it's written from, the third person perspective of clinicians trying to function in the context of what happened to George Floyd. And that is her hometown. Dr. Hardiman made history last month as a Black woman, MPH, PhD. She became the first person in her division in the University of Minnesota School of Public Health to actually achieve tenure. When her school opened in 1944 and her university was founded in 1845. I like to remind people, I'm number 5 of tenured people at UCSF in the School of Nursing in the 14-year history of my school. So when we talk about thinking about public health, health services provision, clinicians, we have partners who've been working on this. We can partner with them if we do our homework to be able to amplify the incredible work that they've already been doing. So simulation public health. What's L? L is lead. Everyone on this call can do this right now. The staff, the housekeepers, the unit clerks, the nurses, the respiratory therapists, the security people at the hospital. They are looking to us to lead, to acknowledge the harm, to ask people how they're doing, to listen. If we want to continue to perpetuate healthcare hierarchy and we want to say we are the leads of teams, let's do that, right? Let's model for people how to listen. Let's introduce them to oops and ouch, or whatever mnemonic helps you to have some accountability to say, we are prepared to listen and to have a difficult conversation. Everyone somehow circled up around written statements this week. And that was beautiful to see, but action has to follow that. So think about your own leadership in your own space. Have you listened to the learners? I mean, Maura told us just a very complex but routine story to me. How many people know that much about the people we serve, right? The learners, the staff, they are looking to us to lead. And we can even model that we don't know how to do this well. And we can do that publicly without stigma, shame, judgment, or blame. But it's showing up and leading from a place of humility that we're going to read in Journal Club, some public health works, because public health has been working on racism and anti-racist practice for the last 30 years. Yes, we're going to watch Maura Jones's Allegories, where she talks about how racism shows up in health encounters, right? You can lead now. Split, simulation, public health, lead. I is going to be tough. I might get some ouches on this one because I means immersion. Maura laid out why immersion is so important. And I will tell you what immersion means. You know, I'm the last person to disparage any basic scientist. Anybody who knows my story knows that I got a free PhD because I was built. I have 3 degrees from public institutions, and I got my PhD when we mapped the human genome. And we thought it was really important to invest fellowships, training opportunities for people to learn genetics and genomics. I think we need the same thing in healthcare around racism. We need a summer anti-racist institute that's funded by the NIH, right? We need journals, special journal articles and editions, partnering with public health authors, really explaining how we do peer review of our science so that we're not continuing to harm communities. I worry that so many of us have gotten so far away from the communities and people that we serve that an immersion is necessary. And that immersion cannot exclusively happen on the backs of the learners or the future healthcare workforce, or those, the few of us who actually have been, able to break through in academia. I can never explain to people how oversubscribed I am. And people always say to me, "Oh, Monica, I'm so sorry you're overwhelmed." And I say, I am not overwhelmed. That is a personal characteristic. I am oversubscribed, which is a structural one. So we can't fix individuals, but we can actually fix structures. Which brings me to a quote I want to read to you, because I think this might be helpful in decreasing the ouch, okay? Dr. Maura Jones defines racism using the following definition. It is a system, a structuring opportunity, and assigning value based on the social interpretation of how one looks, which is usually what people call race. That unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities. And it saps the strength of the whole society through the waste of human resources, right? We're all spending a lot of time, wasting a lot of time because we can't find the skills and the courage to be able to make this different, right? So in Split, so far we got simulation, opportunities to have a place space to work through some of this, where, we can be accountable to each other, where we can know how to self and auto correct. We have public health colleagues who have published, written, read about this, talked about it, been on YouTube about it, where we will immerse ourselves in their understanding. We have to currently lead, and this is a chew gum and walk situation, right? Our staff need to know that we care about them. The learners need to know that we care about them, that we are not only willing to follow their lead, but that we're there with them. This is not on their backs, right? The future healthcare workforce can't be the only people that are responsible for making this different. I know a lot of people always want to say, "Oh, the kid's gonna make it all right, it's gonna be better." No, actually that abdicates our responsibility, right? To give them what they need to be successful in the future. So the last piece of the T, and this is the heart, right? Split. Simulation, public health, you can lead right now, we can immerse ourselves right now. T is tension. And I don't mean it the way that you think, right? And this one's gonna be hard to hear because it was hard for me to experience. But you have to hold the tension of opposites. Monica, what does that mean? I'll give you an example. When I was a PhD student, I was an expert nurse. I had been a nurse for a long time when I went back for PhD. And the tension of opposites I had to hold was I was expert in one domain, clinical care. I could put your IV in with my eyes closed, okay? But then I was novice trying to learn genomics and to do laboratory science. And that tension was really hard to hold, right? That's where we are as healthcare providers, right? We have clinical skills. We think we understand, like tasks, we can do surgery. We can diagnose things. We can go through, algorithms. We can, prescribe things, right? We can do that with our eyes closed. But this other more uncomfortable, where we feel a little bit more novice, we got to hold that tension of opposite, right? Because legitimacy in one domain doesn't give you legitimacy in the other. As much as I would have loved to say I can put my IV in or put your IV in with my eyes closed, that didn't help me when I had to pipette mils per liter, right? Different skills. We have to collectively decide to hold the tension of opposites. That it doesn't mean that we are a horrible physician because our skills are not aligned in being racially literate and anti-racist. We have got to let that go, right? Because if we as physicians and nurses could have fixed this, we probably would have already. We're fixers, right? That's what we want to do. And everything I've told you is exactly the opposite of what we need to be doing right now. Because, you know, this is going to be a really painful statement to make, but I've said it to the School of Nursing, and I'll be saying it to nursing more nationally. You know, we don't have the range yet to be collective partners to be anti-racist. Some of us are incrementalists and will do the minimum and maybe read one or two of the articles we sent out, right? Some of us are going to like try and go burn hospital bed, right? That's the continuum. And what we have to understand is, you know, how people choose to seek and obtain liberation all have to be some path that we have to be willing to try, because what we're doing right now isn't working. So with that, SPLIT is simulation, remembering that there are public health tools. You do not have to figure all of this out. Our colleagues in public health have given us a huge gift. I highly suggest that if you have opportunity to have a webinar or journal club or other, you know, sharing of scholarly and scientific data. I know there are 3 pregnancy-related registries around COVID-19 at UCSF. One of the things that we're really trying to get people to understand is the critical race theory lens that is necessary for us to be able to look at those data, right? We can lead right now. We can immerse ourselves, and we can hold the tension of opposites. The SPLIT should really allow us to then, it should open up a whole new like set of interventions that we can try that will then allow us to take some collective action. We need public accountability, and that's why organizations and groups like the Black Mamas Matter Alliance are so important. That's why we need to have our perinatal equity collaboratives. That's why public health has been so successful, our MCH colleagues. But the truth of the matter is we're doing really hard work in an inhumane system at a time of 2 pandemics. And as Billy Avery taught me, we have a novel pandemic, which is COVID-19, and we have an old pandemic, which is racism. So what are we going to do? What are we going to do? Susan, how do you want to handle questions and answers? Are there things in the chat that I should be paying attention to?
We don't have any specific questions in the chat yet, and so I think that it might be a great idea for you to lead with some of the things that you might want to help us with the conversation.
Absolutely. So I think case scenarios, I see one. Can you explain immersion a little more? Absolutely. So one of the things that I think, you know, immersion is a 3-pronged approach, right? You have to immerse yourself with community. And the way I do this is, you know, I spend a lot of time doing community engaged work. When doulas ask me to come to stuff, I come to it, right? When the breast friends and the lactation consultants ask me to come to things, I go. When there are community baby showers with the best baby zones and some of the public health initiatives that happen before people come into hospital and clinic doors, I go. For the people at Kaiser, sometimes there are opportunities where there are community events, you know. Amanda Calhoun asked me to go, I went. We have to be in community, right? I live in Oakland. And so when there are opportunities for me to show up as Monica, as a clinician, as a public health person, I do. I spoke at the church down the street from my house, and I'm not a churchgoer. I'm not even a believer. But I think it's really important that we show that we are worthy partners to community members, and that we show we are authentic in standing with them as we try to fight for rights. So that's the first part of immersion. The second part of immersion means we have to read. I say this to people all the time. When I wanted to learn mass spec after I finished the PhD, because I'd done some ELISIS and some Western blots and some GWAS, I was like, I might want to do some mass spec, right? Look at low abundant proteins. I didn't walk into a mass spec lab. I didn't go into Susan Fisher's lab and be like, hey, I'm gonna use your equipment right now, right? I had to read. I had to take some classes. I had to think about what's the best way to do. We're scientists. We're clinicians, right? We have to get past the discomfort that we might be novice in something. This is why immersion is related to holding the tensions of opposite. Ending racism has to be just as important as fixing preeclampsia, because they're the same side of a different coin, right? I mean, I have people who can, talk about the molecular pathways around placental function, and they can't look me in the eye and tell me that they understand how patients are going to be able to get nutritious food in the postpartum period. To me, all of those things are connected. They're not separate. And at some point, if immersion is nothing more than understanding the context in which pregnancy happens that goes beyond the body of the pregnant person, then we might be able to have a conversation where we can participate in collective action. See, because here's the thing, ACOG District 9, right? The train is out the gate in terms of wanting to achieve racial justice, right? I am a Gen X person. These young people, they way beyond, I frustrate them because I'm not radical enough for them, right? So some of us are gonna get left behind if we are not able to think about where on that incremental spectrum we are and we wanna be. So that's the other thing about holding the tension of opposites, right? I wanna be aspirational. I want to say I'm going to be in the street and burn everything down. I know that's not true, right? So I'm a model for you what that kind of vulnerability looks like, right? I want to be on the street with folks. Can't. So, and that hurts because I like everyone who knows me on social media knows I like to call myself badass, right? So, and yet I haven't physically been to one protest. And that frustrates some people, right? So, and people who see me in positions of power expect me to wield it differently. And the truth of the matter is I have just physically and emotionally not even been able to write. And for people who know me, I'm a very prolific writer, right? Now, I have written 5 COVID-related grants in the last 6 weeks that have been funded. That's a whole other conversation because I want to shore up community engagement for the pending recession that's going to get spawned by this pandemic, right? So if we all have an anti-racist lens, we're going to think about what innovations have come forward that we've been fighting for years that we should be fighting for right now to remain permanent, right? CMS never promised us that they'd compensate us appropriately with expanded opportunities for telehealth prior to COVID-19. 6 weeks ago, that all went away, right? Or when we think about the fact that we could never send people across state lines to be able to, provide, reproductive justice and reproductive health services, abortion, family planning, contraception, where it was most needed in the country, because despite national licensure, we were not able to send people to other states. And all of a sudden, 6 weeks ago, UCSF is sending people to Navajo Nation in Utah and in New Mexico, and we're sending ICU workers to New York City. How about we make that permanent too? Can't we use some of your muscle as a professional organization to show that you sit on the side of Black lives, right? That's where I'm at. That's where Monica is at. Because if we expect structures to be able to survive and thrive post-COVID-19, what are we prepared to make permanent? I'd like to remind people of three things, right? Number one, we're expecting 2 Supreme Court decisions in our field any day now, right? June Medical Group versus Russo, which is the abortion case out of Louisiana, and Pennsylvania versus Azar, which is the Hobby Lobby Part 2 case looking at contraception and whether and the employer-sponsored mandate, right? You know, so as we think about that, as we think about our judiciary, as we think about Congress, everyone forgets, you know, there were 9 groundbreaking bills that were introduced the day before we all went to national shelter in place called the Momnibus, right? 9 bills from the Black Maternal Caucus, ACOG National, signed on to those bills. They're not dead. We can fight for those. One of the most depressing things that did happen, though, a week into shelter in place, was that the 14-county Medicaid doula project bill that me and my team and a whole lot of other folks have been working on got pulled from the California legislature. And then we'll have to wait until the next legislative session in October because Governor Newsom is worried about, again, the state budget because of COVID-19. We could fight for that, right? How about physician supervision of midwives here in California? We get on that. I keep going.
We have a couple of questions that I wanted to get to that I thought would be really helpful for the group. How do we open the conversation with patients to help start the discussion of their fears and realities of racism within healthcare?
Let's try these questions. So I lead with curiosity. I find curiosity is most helpful. And asking questions and being prepared to listen is what I found to be helpful. So, you know, one of the things, and this, you know, I mean, this comes back to how invested are you in changing these things? So when you walk into a room and you're trying to get people taken care of, you know, what is the thing that you want me to hear today? What do you want to talk about? I know you got booked for appointment. I know, like, what do you want me to know today? Right? What do you want to say? Whether it's about your appointment or not. Give people the space to tell you what they want. Some people don't want to share with you. They don't know us. They're coming in. They want to get what they want to get and they're out. Right? Some people want to talk. They want to know that at least we care. You know, I really appreciate you asking me that. I can't really talk about this today. Right? But if we don't ask, there's so many assumptions in that. Yeah. And I think, and even if, you know, if you're in a telehealth visit or if there's some statement, everybody's like statements. How about a statement? We care about your health. We are open and willing to talk to you about, you know, current world events and our anti-racism efforts. We are just getting started, right? But to me, it's more, if you don't say anything, everybody's acting like it's business as usual. But then nobody knows what to do, so it creates this whole other loop of, well, then I'm not going to ask, and we just going to actually pay attention to this thing, and then it never goes anywhere else. So vulnerability and courage would be what I would be thinking about, and especially in like the context of telehealth. Right? I get that like having people sitting for 3 hours in your waiting room is one thing, but like maybe just try it on telehealth. Right? Can we have a group appointment on telehealth so that like people can talk about like whatever, but like being stifled does not allow us to try things. And people are so afraid of failure, they feel like the stakes are so high that then that reinforces not trying anything. And that's how we stay here. Right? And so for me, I feel like it's time to try the stuff with authenticity, vulnerability, and transparency. And that's why oops and ouch hurt. Like they work. Or some way that you can communicate with the people that we serve that we're not expert, we're not gonna get this right at all. But we care about you enough to ask. We care enough about you to listen. And that probably won't be enough for some people. But we have to begin to invest ourselves in understanding that we're not good partners and we need to work on being better partners. Mm-hmm. That's what I would say.
Yeah, thank you. We have a couple other questions that in terms of what are key strategies to influence systems and structures when our influence feels like it's on an individual level?
I actually don't agree with that. I actually think that, you know, and perhaps maybe this has been my own personal experience with professional organization, but I have forced many organizations, the Association of Women's Health Obstetric and Neonatal Nurses to be one of them. And now as the chair of sectional reproductive health, I'm not sure that everyone heard this, the APHA annual meeting, which was supposed to be in San Francisco this year, has just decided earlier today that it will go completely virtual. I have been relatively successful in trying to circle up professional organizations to leverage collective power, right? So your district is one of, if y'all 9, I assume there's 1 through 8. And so
and 12,
yeah. Right? Or whatever number y'all got, right? One of the things that's really hard, and this is probably gonna be an ouch moment, but it's really hard for me to hear people who want to be who claim the top of healthcare hierarchy to then claim being powerless, like in other areas. Like that to me, I really, if I was going to use profanity, I would have to use profanity there, because that is the one thing that sort of really makes me crazy. So let me turn the question back to you and say, okay, in the context of our current environment, what's District 9 prepared to do and demand in order for us to be able to leverage our collective power? So this past weekend, a lot of Black nurses and midwives got really grumpy because the American College of Nurse Midwives thought it was a good idea to host a virtual dance party on the day of George Floyd's funeral. So we all withdrew our dues. And, you know, it was interesting because our call was that people should pay money to a fund that was going to Black midwives. And they were able to raise something like $8,000 in doing that. What are you prepared to do, right? Either we care about the people we serve, our learners, the staff, or we don't. So we should think about collectively, what is the district section prepared to do to leverage the power that you have, whether it's financial or collectively institutionally, right? We saw shut down STEM today that was being led by Particles for Justice, right? If the physicists can come together on the atomic level and ask that the entire nation shut down STEM for people to be able to reflect, you could build off of the good fortune that maternal child health has built in public health space and really be able to demand different kinds of things. I'll give you 2 examples. Number 1, you know, Black Maternal Health Awareness Week was put into place in advocacy space by Black Mamas Matter Alliance. And I've seen a lot of people really celebrating and uplifting and hosting events and doing those things, okay? How about Black Mamas for Black Lives? Why don't we have a day of observation, of joy, of lifting up Black moms some point, maybe around, you know, Juneteenth, you know, or some other day in the future where we think it's important for us to acknowledge Black moms. That's not Mother's Day and it's not Black Maternal Health Awareness Week, right? Why don't we think about a way to provide, you know, an award or some acknowledgement, you know, to people who do community engaged work and who are immersed in community, right? What other tools y'all got in your toolbox? See, I don't know your professional organizations as well as I know nursing organizations. So, you know, if there are other ways that you can leverage humans, money, and time, which I'm assuming the resources are that you have, then I'm happy to think with you around how to leverage those. But do you have any resources besides humans, money, and time? Do you have the building? Do you have like real estate? Can that be opened up to community groups, right? What other resources do you have? Do you have, you know, Zoom platforms or other things that people need in order to think about, you know, getting communities what they need.
Yeah, no, these are great ideas.
How about co-sponsoring postpartum meal delivery to people in the community?
Yeah.
Especially since we know that 40% of maternal deaths happen in the postpartum period. Why don't we partner with like Mothers to Mothers Postpartum, or, you know, Uber Eats or DoorDash or somebody, and say, hey, we're gonna have a day where we're actually going to deliver, you know, no cost meals to postpartum moms. Sign up here. Here you go. Instagram. Right? Start small. Or if you're gonna leverage humans, money, and time, then create a master calendar. And then whose work are you going to lift up? How are you going to flex that muscle or stress that muscle to really become, you know, a collective agent in the space? Right? We need more people. This is why stifling isn't helpful, because it doesn't allow you to see past the frustration, the fear, the guilt, we could be thinking about some really, really fun things that we could be trying to do to try and innovate in the space. I have always wanted to do some kind of like postpartum mom gifts, like just randomly sending people something, you know, week 1, hey, your new parent. You get food this week. Oh, we're gonna have doula come this week. Oh, we're gonna have foot massage this week. Oh, like I would love for somebody to do like a holistic, you know, postpartum, you know, public health, clinical health partnership kind of thing. I would love for somebody to do something like that. But we can't, I worry that too much of our focus is on inpatient, you know, birth experiences, when that's its own thing. Communities, Black people, Black women need us to show up in ways that I think are important. And if you want to stay in your lane, which is totally fine, right? Well, at least it's honest. At least, you know, be attentive to the staff we work with, the learners we work with, and the people we serve, right? That's how I think about it. I want people to be bigger, but y'all are like one section of 12. So that's why I got to address the national economy, and I won't, right? I mean, so, but it's a both and, right? We have to get out of this. We all have to do everything. We all have to do our part, which is different than we all have to do everything.
Yeah.
Make sense?
Yeah.
I saw another strategy question. I'm a big fan of strategies, and I am listening. Like somebody put in, residents came together around national bailout. That is one of my favorite groups in terms of really thinking, like, we really need to stop. Our foot should be down around incarcerating pregnant persons, right? I mean, we should not be incarcerating anybody, but the truth of the matter is, can we at least get everybody to agree that pregnant people shouldn't be locked up? Can we just like, let's start there, right? I'm channeling Carolyn Suffering because, you know, I miss her tonight, but many of y'all know Suffering because she was at UCSF and now she's at Hopkins, right? Doing incredible work with carcerally involved pregnant people, right? Can we just have a campaign? Maybe ACOG's job in District 9 is we're gonna take on, we're not gonna have any pregnant people in the San Francisco jail. We're not gonna have any pregnant people in Santa Rita. You know, we're just not. We are going to create something else.
Thank you. And I will point out, ACOG District 9 did a lot of work on a law to prevent shackling women.
The anti-shackling, yes. Okay, so what are we doing next?
Yeah. Yeah.
What else are we doing?
So I wanted to ask a couple of questions about, so in terms of, there's one, strategies to have these conversations, particularly with colleagues within department, without hurting feelings and professional relationships. So do you have some strategies about how to initiate these conversations, how to feel safe in having these conversations?
There is no safety in these conversations.
I thought you were going to say that.
Now, there are more safe ways to have them. So I'll give you some strategies that I use. I never talk to anybody alone. Mm-hmm. I sometimes initiate conversations in writing by email, and I keep a running Google Doc of those emails because I think it's necessary and important for accountability. I request that when conversations, you know, need to have safe words, so like when they need to end, they end, right? Regardless of where we're at in time. There are ground rules. that you can create to help make some of these discussions, you know, more productive. I won't say, you know, safer, because talking about race and racism is not a safe discussion for anybody, and especially not for Black, Indigenous, and people of color. It just isn't. And so, you know, when people bring things to me, especially when I'm wrong, I have trained myself, again, going back to simulation, the first thing I do is thank them. Thank you. I really appreciate you bringing this to my attention, you know, and I have had to apologize to people, like people on my own team this week. I snapped. Okay, so let's do vulnerability here. I snapped last week and I had to close my laptop on Wednesday. And for people who know me, you know I generally work with Black, Indigenous, and people of color. And I was meeting with some early career investigators that I do a lot of work with. And I literally like snapped. Like I yelled in the email and just sent back some things that I you know, had I thought, I probably wouldn't have written. And when I found myself like going to type another like really hateful email, I was like, you know what? I'm going to put my out of office on and I'm going to go sit outside with the dog, and I'm going to come back in and I'm going to write an email and apologize. I'm going to text them and offer them a voice apology for my behavior, and that we were going to have a discussion about it. Self-scanning is important because it shouldn't just be on learners who were brave enough to bring things to us, or staff who bring things to us. It shouldn't be on them to be scanning for us and our behavior, right? Again, going back to the future, can't always be like the source of accountability. So one thing I always do with our colleagues is, you know, I text Joya a lot. I texted her when I realized that I had actually like snapped at one of our early career investigators, you know? And I was like, oh my God, I screwed up Joya, right? Who are you accountable to? Oh, y'all. Do you have people that you text? When you put your foot in your mouth, or you say something really dumb, or a staff person calls you out for something that you say that's racist, or the residents say something to you, who's the first person you text? Do you thank them? Right? It's a gift. They could have cussed you out, right? I think we need a reset of normal. I think we need a reset of safety, and I think we need to model it, right? Mm-hmm. Because if we don't, this doesn't change. It really doesn't change. And I think simulation helps with that, like, gotcha piece. Like, people wouldn't be coming to you and having it throw you off if you had a play space to simulate, right? So that's why I keep saying, you know, whatever I don't know how often y'all meet. I don't know if it's a monthly or quarterly or whatever y'all do, but maybe y'all need to create like a practice space, right? Or a virtual reality situation where you create that's the other thing. We need some virtual reality modules that help people to walk through some of this, in addition to like real world accountability, right? And people have done this in intimate partner violence space where they have upstanders and bystanders. And the upstanders are the people who actually have been trained and know how to intervene and de-escalate situations. And then the bystanders are the people who just sit and watch, right? Maybe we need that kind of simulation as well, right? Because a lot of times, I don't know if you're like me, I'm not a fight or a flight person. I'm a freeze person. I'm deer in the headlines when people say stuff or do stuff. I literally have to stop because I'm just like, I'm a freeze person, right? Simulation has helped me get past freeze and really talking through some of these issues. But you have to make the investment. That's the other thing. You know, this can't just be a one and done. It can't be a one-off, right? I have asked the OBGYN department to start to think about how we use our grand rounds. Everyone thought it was important enough to have M&Ms. Maybe we need to have anti-racist grand rounds on like set in the schedule.
Mm-hmm. Well,
right?
I thank you so much. I also want to thank a lot of people in the chat have posted some helpful things as well. And I'd like to, and thank you for these concrete ideas about things that we can all do. I'm going to read this one comment in closing, and then we'll need to wrap up soon with Dr. Silla. For white people trying to have conversations and worried about being uncomfortable, it can be helpful to keep in mind that Black and Indigenous people of color folks are subjected to pain and discomfort around race on a daily basis. So I think that I've appreciated so many of your comments today, Monica, just with giving us these ideas about things that we can take action on, and we appreciate that. I'm going to turn this over to Richie, and thank you also to all of you who have participated and put very helpful information in the chat. So thank you. And, oh, Richie is muted. Sorry, I'm not going to retire. There we go. And do Zoom.
So for everyone, I just want to remind you that I did email the list of resources to you right before this meeting. If you didn't get it, please do reach out to me or Susan to make sure that we get you that list. Feel free to circulate it to whoever you feel it might be useful for. It includes the book and the archived webinars that Dr. McLemore is referring to. At the end, there's a link to a 1-hour workshop being held by Dr. Akila Kadei, who lives here in Oakland. And it's she's going to talk this talk for physicians, just using how to use our power and privilege as physicians. You know, we are the leaders in our hospitals, and how can we be part of making change and dismantling racism within our institutions. And this is for any physician, not just OBGYN, so feel free to share it also with your colleagues in any department. And this is just one of many ways to further our learning. And as we do anti-racism work, we will make mistakes. We will unintentionally do or say racist things. It's important to remember that it's inevitable because of the systemic racism that we grew up in and live in every day. And I want to challenge everyone that when we do make these mistakes, to stay humble and open to growing so that we do not further anyone's pain. We can learn from our mistakes, continue these conversations so that we can create better health for all of our patients equally. So thank you so much for attending, and we look forward to continuing these conversations.
Thank you. Bye.
Thank you, everyone. Thank you so much, Monica, and everyone who participated today. Thank you for being here.